Looks like the admissions from the waiting room have slowed down a little bit. And so if it's all right with everybody, we'll officially get started. I'll start out with just an introduction and introducing all of our panelists. I'd like to welcome everybody to the 9th of our series in the COVID virtual town halls. We were hoping that our last would be the last one necessary, but we've had quite a few changes and would love to get some new questions answered. So we've asked our fantastic panelists that we're very grateful for committing this time to come back again and review some of the newest information. The panelists include Dr. Margarita Cabrera-Cancio. She's the medical director at Infectious Disease Associates of Tampa Bay and an affiliate professor with the Department of Internal Medicine here at the USF College of Medicine. We have Dr. Douglas Holt, health officer for the Florida Department of Health, Hillsborough County, and professor of medicine here at USF, also in the Division of Infectious Disease and Internal Medicine. We have Dr. Cami Kim, professor at the College of Medicine in the molecular medicine director in the Division of Infectious Disease and Internal Medicine, also a joint professor at the Center for Global Health and Infectious Disease and involved with our College of Public Health. We have Dr. Johnson, scientist and chairman of the Internal Medicine Department at the USF Morsani College of Medicine and director of the Florida Infectious Disease Institute. Again, I'd like to thank you guys for your time. We really appreciate having experts that can evaluate, our current situation and the changing COVID landscape from a few different perspectives. We'd like to welcome members of the Hillsborough County Medical Association and some of our panelists positions to the town hall, and we are ready to get started. I tried to put together a little bit of a set of sections so that we could try to answer different questions within different aspects. And I will direct questions to panelists, but certainly if anybody has additional information to add from your perspective or your current practice, please do join in. I'd like to start with Dr. Holt from a public health perspective here in Hillsborough County. The current strains, mainly BA.5 and 4, seem to be quite highly transmissible. The newest data looks like they're the predominant in the entire United States as well. Does prior immunity or the vaccine series seem to have less of an effect with this variant? And does it seem to be only in limiting severe disease, or have we seen any transmission data that there's benefit from prior immunity or vaccination?
Yeah, thanks. Oh, thanks for the question. Yeah, it appears to be that it does not provide the degree of protection from an infection itself. The immunity is not engineered ideally for the Omicron variant. But as far as illness and severe disease, we are still seeing lower severities in the patients that we're seeing. So we're in a fourth wave, or our current wave started in early April. We've seen a gradual upslope, much more gradual than in the past. We peaked mid-June. We're sort of flat now. We're seeing about 650 cases a day. That's an underestimate, we know, because the testing is just much less than we had previously. And therefore our positivity is up about 20%. Hospitalization, as you noted, actually went up. We were running as low as 10 a day. I think it's up to about 30 a day across all the systems. But some of those, just talking, and again, Dr. Cancio, some of the practitioners, seems like they're picking some up. They're not admitted for COVID, but they're finding them in the hospital. And that's kind of, I'll stop there. And
I think that it's also important to understand that the protection for real disease, for severe disease, is better with vaccines than it is with the disease itself. The disease itself does not seem to protect as much. So it is. So vaccines are still really important because it protects from severe disease, and getting individuals vaccinated and booster is important.
That's a great segue. The next kind of the first topic, I guess, I was going to review are vaccines and what's new there. since most vaccines confer several years, if not lifelong immunity to viruses that are the target, is the COVID vaccine really similar to the influenza vaccine in that the rate that the virus is changing, we're going to need yearly boosters and or new vaccines each year? I guess I'll ask Dr. Kim if you have any insight there.
Well, I think that's what it would expect. Coronavirus naturally, and SARS-CoV-2 is a type of coronavirus. It seems like the immunity, the antibody levels decrease over time with all coronaviruses. And then all viruses can change and mutate. And obviously SARS-CoV-2 has been particularly adept at mutating. As Dr. Cancio said, the protection is very strong from vaccines, from serious disease and things like that. I think some of these Omicron strains may be less virulent, but I think a lot of the reason we're not seeing as severe disease is because a lot of people have partial protection. That being said, we still have a lot of vulnerable people. You know, we have kids, we have people who are immune suppressed, and we have new variants coming out. So I think we don't know exactly what the recommended dosing is. A lot depends on what happens as viruses emerges and things like that. But I think most people think that the vaccine is very, very efficacious, that the antibody that's present prevents you from getting new infection, but the preserved T cells and other things prevent you from getting really severe infection. So even if you get COVID, you're going to get a mild disease. And so that's better than landing in the hospital on a respirator and things like that. But even with all of that, we're going to have to modify the vaccine to respond to the newest variant. So I think that's absolutely true.
Dr. Sinnott, I'd like to ask if you're with us. Do we know how long it takes for the typical mutation to occur? Is that something that's predictable in the coronavirus, or would that also be variable with how much change there is from strain to strain?
Well, it is mutating every time it infects a cell. It is constant mutation. 99% of mutations hurt the virus. It doesn't work as well. So a new strain could arrive in Lutz or India or Antarctica. You don't know where. So it would be better to drive the infection rate down. Tragically now, for us as a race, the virus has found its way into animals. And the last two variants have clearly been from white-footed mice, not from people. So once it's mutating in animals, all bets are off. If it were just humans, we could assume sort of a lessening of virulence over time because it's the virus's advantage to not kill people and be spread. But if it's coming from animals, we run the risk any day of something new happening. Does that help you understand?
It does. It also sounds much more concerning than it had previously. Just curious, do animals show symptoms, do we know?
Oh, yes. In zoos around the world, hundreds of great cats, animals like lions, tigers, leopards, routinely die of COVID. And they're now treating some animals with COVID because they're so valuable. So far, it seems to be the great apes and large cats. But tomorrow it could mutate to infect cattle, which would be catastrophic for the food industry. We mustn't underestimate the danger of this virus.
Thank you. It's fascinating. That's an entirely new topic I really hadn't thought about. It's interesting to see how that will translate into the future and where we go with potentially treatments and vaccines if we have, other strains that may come from the animal population.
We can let me draw an observation. Denmark was the second leading producer of mink, like for mink coats, in the world 2 years ago. Now there are no minks in Denmark. It got into the minks, killed the minks, killed a bunch of people caring for the minks. So they just got rid of the minks.
Wow.
And that could have been cattle or pigs or chicken.
Mm-hmm. Regarding the boosters that we're hearing will come out specific for the Omicron variant, we have a few questions regarding those. I'll ask Dr. Cancio if you have any insight in educating our patients or making recommendations. If somebody has already had 2 boosters based on the current CDC recommendations, should they get another since it's specific to this variant? And conversely, if somebody hasn't yet had that booster but is interested, do we encourage them to wait for the new strains coverage?
Well, the most individuals should have had 2 boosters by now if you have not had the second booster. And by the way, that does not apply to transplant patients. Let's make sure that we understand that the immunosuppressed population, the initial series is not 2 shots, it's 3. So once we put so they're already in they're on the 5th dose. So outside of the transplant population that would need 3 as original baseline vaccine, then the boosters have been kind of like every 6-7 months or so. They are testing currently. There is what is called the bivalent vaccines. Both Moderna and Pfizer are looking at these bivalent vaccines that are going to be more specific for the Omicron variant. And actually, FDA has given the go-ahead to try those. We're hoping that those will be available by the fall. So it all depends on when your last booster was. If your because you want to be covered. If your last booster is more than 6 or 7 months ago, you may want to get one. If you have had one within 6 or 7 months, you probably can wait for the new more specific also bivalent vaccine that should be coming out sometime in the fall, or so we expect.
Would you also be able to comment, there were some news outlets discussing some of the data and recommendation of switching manufacturers, for example, from Pfizer to Moderna or vice versa, because there was a thought that there could be potentially a better coverage given that they're slightly different.
Well, I think that the fact that Moderna gives you a higher coverage, so to speak, I mean, higher levels, and it was because the dose was higher. Remember that the Moderna vaccine had, in the original vaccine, had 100 micrograms, and then the boosters were 50. The original Pfizer was 30, and the boosters are the same. So and for example, specific populations such as transplant population, individuals that have a compromised immune system, we recommend Moderna more than we recommend Pfizer because you have a stronger immune response. And at the same time, you may have a little more side effects because you have a stronger immune response. So I don't think it matters whether you cross over or not, but all of that came basically because Moderna was giving a little bit of a higher immune response. But there's no data to say that that you would have any negative outcomes or any negative side effects from going from one vaccine to the other. So everyone at the beginning tried to get whatever they had available. And then when the boosters came around, I think the majority of people kind of like went towards the Moderna just because it was giving a higher immune response.
Joel, are you able to speak at all on the new Novavax vaccine that was just approved here in the United States?
Well, the Novavax vaccine is a recombinant protein subunit, and it has a matrix M adjuvant. So it's a very traditional vaccine. It is a very traditional vaccine. So we think that, hopefully some of those people that are a little afraid of the messenger RNA vaccine will find it helpful. In the studies, it looked really effective for individuals under age 65, 90+% effective. Individuals that were greater than 65, the effectiveness decreased a little bit. I think it was something like 78 to 80%. But again, for people that don't want any other vaccine, that should be, because should be a good option, because it's a more traditional type of vaccine, and again, it will be, you know, two shots, and that could be a good thing for those patients. However, we do have to point out that all the studies were done prior to Delta and Omicron. So the studies were more from the beginning. So is the effectiveness going to be now for Omicron and for the same 90% for younger than 65 and 70% for greater than 65? That's unclear. We have seen the other vaccines that are so effective provide some good protection for severe disease, but not for infection. So I guess we'll have to see what happens as the vaccine is used more. And it also only being approved for over 18 years of age.
So one point about the Novavax vaccine is because it's the traditional technology, there are a lot of places that don't have fancy freezers in their clinic or wherever, whereas most facilities are equipped to give influenza vaccines and things like that. So in rural areas, smaller clinics, in the developing world, where vaccines have been much more difficult to give out for a lot of reasons, the Novavax vaccine could have a pretty big niche, particularly since the AstraZeneca and the J&J vaccines also seem efficacious, but because of the side effects, they seem to have more adverse events. So they had some of the same advantages, but it seems that they're going to be used less because they had more severe side effects than the mRNA, and the Novavax, as far as side effects, seems to be comparable to the mRNA vaccine. So I think the Novavax, even though it's one of the ones that came in later, it may well be able to be mobilized to other places where people want vaccines, but they haven't been able to get them.
Dr. Holt, in the public health sites, I'm sure you see an opportunity to give multiple vaccines at any time if patients are willing. Can you speak on the safety of giving the COVID vaccine at the same time as other vaccines, such as influenza or hepatitis, or really any of the vaccines that we can give on a regular basis?
Yeah, we will give them simultaneously at the same time. They can be given, and generally, besides some soreness and some irritation at the sites, we've not had anybody really having any problems from taking combination of the vaccines.
How have the public health sites been handling vaccines for children, both under 5 and over 5? Is there an education piece that's going out to the community? And what have you seen in our area in terms of statistics of utilization of those vaccines?
Utilization has been low. The state Department of Health had a bit of an unusual policy where they judge that they do not recommend the under 5 vaccine. So the health departments for this population, we did not receive any vaccine, and we're not administering it for that population. But across the board, we're seeing really a low number of vaccines, in the entire population.
Was there a specific time when it seemed that the statistics dropped off of kind of the influx of vaccines and new vaccines or new patients with vaccines? And if so, when was that?
Yeah, I mean, really, we had an amazing response in that first probably 6 months or so when the vaccines were first released. We were vaccinating 10,000 people a week or so. And now it's well under 1,000, and that's just across the country. So we hit about little under 70% of our population vaccinated, which is not bad. But then it hasn't moved an inch since then.
And I believe that's roughly on par with the United States as a whole. Florida really is right in the middle of the road from what I've seen in total.
Yes. Yeah.
I was going to move on to testing, but I'd like to open up the floor to all of the panelists. Are there any other important components about vaccines, whether it's the vaccines themselves, any new information or magic words for the vaccine hesitancy that still is prevalent in some of our patient population before we move on to discuss a little bit more about testing? Or if there are any members that are watching, I see some questions that we'll get to if there's any other questions specific to vaccines right now.
I think it is important to know that children have died of COVID. And I think the last statistic that I saw is something like 450 under the age of 5. And the CDC has recommended those vaccines. So even though the state of Florida has not endorsed that, I think that CDC has recommended, and traditionally physicians follow CDC recommendations when it comes to vaccination.
And I think that the other thing that people need to recognize, and those of us who are infectious disease people or public health people know, that is not only do children get potentially severely affected with COVID, but children are frequently the people that bring virus into families and communities and things like that. So even though children may not get that ill, pretty much all vaccine studies have shown that not only do we prevent illness in the children, but we effectively prevent the adults that they live with, particularly immunologically vulnerable adults. So vaccinating children is important for children's health, but it's also important for their loved ones who are adults, older people, or people who might be immunologically vulnerable.
That's a great point. We love them, but they're fomites. They bring any and everything home. Transitioning over to testing, I think this is an area I actually had quite a few questions on because my recent COVID infection at the beginning of June evaded an at-home test for quite a while. And so the biggest question is really how accurate are most of the at-home tests, those that are cleared or given for free through the government program that you can get. If Dr. Sinnott's with us, that sounds something right up his alley in terms of the science and the efficacy behind the testing at home. Muted at the moment. Oh, you're muted, Dr. Sinnott.
An at-home test is very valuable. It doesn't correlate perfectly, but it does suggest that you're contagious for other people. Secondly, it gives you sort of an architecture to begin a treatment regimen to treat the patient, which would most likely be Paxlovid, or if they're on complex medications, molnupiravir. The tests are getting better every day, okay? In general, if you have a positive test, you have the virus. False positives are extremely rare. If it's negative, you're not sure. You probably need to have a couple tests. There was a very interesting study done of patients of when during the day are you most likely to have a positive test. It turns out to be 2 p.m. Why? I have no idea. I suggested patients that have even mild symptoms that they test for COVID, okay? The first 5 days of COVID are actually dangerous. That's when we have unexpected clots with myocardial infarction, stroke, or venous thrombosis. So I'm quite aggressive with early treatment. Everyone I see early gets either Pax or molnupiravir. Additionally, if they have any risk factors at all, they get bebtelovimab, okay? Now, why am I so aggressive? In 2003, I was in China for SARS-1 and sent there by the government. I spent almost a month there. In that time, and this is a much different disease, we sent many people home that we thought were well. But 3 and 4 and 5 years later, they started having long-term complications. One of them was memory loss, another was peripheral neuropathy, and some that had bad pneumonia had progressive pulmonary disease. So I would tell you, we've only had this disease 2.5 years. No one knows what the future holds. And that's why I stand with Margarita and most, if not all scientists, that children should be vaccinated. A perfect example is polio. The last case was 1962. It wasn't until 1980 that people recognized it was a post-polio syndrome. And then they look back, and all these patients that had these complaints, they chalked up to being psychosomatic, et cetera. Well, they certainly weren't. Now, not a lot of research is done because that group of patients is dying out, but that also was an RNA virus. So I'm very aggressive about vaccination and treatment, not just immediately getting people well, but the fact that I don't know what this holds for them years down the road.
I think that's a very interesting insight. That was one of my tactics to vaccine hesitancy, actually, was choosing unknown side effects from an mRNA virus that people presumed was new technology. It was new in the vaccine world, but had been around for so long that we don't know what the long-term effect of the virus is. And so that you're not choosing something potentially unsafe over something safe, it's really two unknowns. And I think that it will be very interesting to see both in the short term few years and then even potentially longer down the road what we may find. And I definitely do want to talk about long COVID and some of that information in a little bit as well. That's very interesting.
Well, actually, long COVID is seen in the unvaccinated patients close to 50%. Right now, I think I have read something like that, the 40 to 50%. If you have been vaccinated and boosted, you have good, it's like more like 15, 1.5. It's a huge difference. So long COVID, if you don't want to get long COVID, you may as well get vaccinated.
I think that's another piece in our armamentarium for education for patients with the vaccine. Anything that we can provide, you never know what component a patient may really hang on to, and that may be one of them. So I guess, Dr. Kim, and I don't know who the best question or person for this question would be. It's interesting. Are there any reliable antibody titer tests available? And in what potential scenarios might you use them? For example, we've had patients who may have had their vaccine, their boosters, and COVID, and some show antibody based on the serum blood work that we have readily available and some don't. So I'm just interested to know if that's being utilized in any clinically significant ways that we would like to know about.
Well, I don't think that we entirely know. I mean, the official recommendations are after people are vaccinated that you don't use the antibody test, that it doesn't really tell you anything. I think clinically speaking, that's not entirely true. I think particularly in immunologically vulnerable patients like transplant patients, people with immunodeficiencies, for me, I would like to know if they've been vaccinated and boosted and they have virtually no antibody, because those are the people that I would counsel, to be very careful. Obviously these days people aren't wearing masks very frequently, but I would be more vigilant for them and counsel them. And then also for them, I would tell them, listen, you got to live your life. So if you are at a setting where you're exposed or you become symptomatic, get tested really quickly and contact, your physician, to receive treatment. So I think in people who have low antibody titers, that's definitely a situation where I would use those tests. There's also some emerging data that maybe some of these treatments like monoclonal antibodies may be more useful depending on whether someone's antibody positive or antibody negative. That's sort of a open area that we don't know what's going on, but certainly like the Regeneron COVID study suggested that people who got treated, particularly people who were seronegative, had greater benefits. So there are settings that we use the antibody titers. I personally would mostly use it to help triage people who are immunologically vulnerable and try to give them sort of as rational advice as I can in a very uncertain setting. But Dr. Cancio actually is my local expert on those kinds of things, so you should ask her as well.
So actually, I think that it's important that we need to differentiate that there's two types of antibodies. There is the antibody when, which the nucleocapsid, which you had the disease, so you just had the disease. And we use that in therapy when in the hospital, for example, because if you already have antibody, you're not gonna benefit for the monoclonal. The other antibody is the spike protein antibody, which is the one you get from the vaccine itself. And in the general population, we don't check that. But in patients that have immunoglobulin deficiency and transplant patients, we do. And if they're unable to produce antibodies, we actually have a prophylaxis therapy called Evusheld. And Evusheld is actually holding fairly well against Omicron. And that is every 6 months. And that's an IM injection. And we give a lot of Evusheld to our transplant population because they don't produce antibodies and they can be protected. And it now has the indication of for prophylaxis for those patients. And then you have to repeat it every 6 months. And like I said, it's holding against Omicron fairly well, which the other monoclonals no longer really are being available except for the Bebtelovimab that we use as a monoclonal for therapy in those patients that don't have IgG to the disease itself.
Just looking at a question that came in on the chat box. I think it has been answered, but I will ask it specifically so that we can make sure the question's answered. I think you alluded that we don't need to be checking antibody titers prior to doing any sort of vaccination, but the question is specific to children. It doesn't specify under 5 or just under 18, but should they be tested for the titers before giving the vaccine? I know there's always concern about the cardiomyopathy was probably the biggest that is known to the general population, even though the studies show that likely the statistic is the same for the disease and or the vaccine, if not greater if you get COVID than with the vaccine. And so I'd just like a specific answer on, do we need to test antibodies? And again, I think you alluded to it saying that the vaccine is much more of a protection than natural immunity is, but if you can speak directly to that regarding children.
Well, actually the best protection is actually if you got both, right? So if you get the vaccine and natural COVID, the studies seem to indicate that that's like combination protection. So you probably have the best protection with both. And I think because of that, no, I wouldn't bother checking serologies. I would give, people, whether or not they've been had COVID or not, I would give them the vaccine because I think the evidence is pretty, and this is why we boost people, right? You have some level of immunity. So people who had that, COVID, they tend to get less sick, if they get another exposure to COVID. But still, it's pretty clear that the boosts are necessary because that immunity wanes. And so whether you had COVID or not previously, as evidenced by an antibody, wouldn't change my mind whether you needed the vaccine or not. You still would need the vaccine.
I agree with that. The IgG produced by the disease itself seems to go away within 3 months. You can't even, most of the time, you can't measure it anymore. You have a much better response with the vaccine. And the other thing is that children can get long COVID. We have seen young people with long COVID, and we know that vaccine protects against long COVID. And I totally agree with Dr. Kim. No need to check kids. And that question comes because so many kids have had COVID already, but their protection is so short-lived.
I think Dr. Sinnott did allude to this as well, but I'll ask specifically. Many patients keep testing positive even days or weeks after COVID. I'm very interested to hear a little more about the comment that when we are testing positive, that may also have a component of infectivity rate, or how easy it is for us to then pass along COVID. Is there any reason to keep testing? And then I assume that's why the CDC's guideline, if you do their algorithm, tells you to wait and test, and based on that positive or negative, whether you can go back to work and what precautions to take.
You're asking John, right?
Yes.
Okay. The follow-up with PCR is pointless. PCR can remain positive for 72 days. It detects decaying pieces of RNA after being turned over by uninfected cells. Rapid tests can be positive when patients are not contagious. We're not really sure what to make of that. The best study on how long people are contagious is from onset of symptoms to day 8. Seems to catch most of the contagious people. If I had a normal person, not immunosuppressed, that came in day 12 with a positive rapid test, I don't think I would worry too much about that. Now, I looked at they're much less contagious day 8 to 10, and that's what I want to know. Does that help?
Yes, absolutely. That actually is a perfect segue into kind of precautions, isolation, specific to both general population and us as physicians. We had a run of COVID through our practice, and so determining what the safest thing was to kind of rotate, how long to keep ourselves out of work. And so one of the questions I think is great, if a patient came in, and I'll ask Dr. Holt, if a patient came in with a symptomatic patient with respiratory symptoms where they could have been infective, they were negative at home, but then you retested them and you do confirm they're positive, or somebody just calls and says, I was in your office, 1 or 2 days ago and I'm now positive. What measures would you take in regards to any special cleaning mechanisms, employees with any meaningful contact, or the physician with any meaningful contact? What recommendations would you make?
I would not do a terminal clean or something along those natures. I would clearly just standard, your normal house cleaning and all would be adequate. As far as the potential exposures for a symptomatic person, again, hopefully you start getting into, were both of you wearing masks or not? You could kind of subdivide some of that. Worst case scenario, if you do look at them as potentially exposed, then if they are vaccinated, you really don't have to do any restrictions as long as they're asymptomatic. And if they are not vaccinated, then we do recommend that they wear a mask, but they can continue to work under that scenario. If anybody gets infected, and whether they're symptomatic or not, we then recommend that 10 days is optimal for the isolation, but 5 is acceptable, again, depending on work conditions and what your needs are, again, with a mask on, and that they have not been symptomatic for the past 24 hours. If they're asymptomatic and vaccinated, they really don't have any restrictions. If they're not vaccinated, you sort of have to assume that they are symptomatic, so you end up treating those the same.
In the same vein, if somebody then does become positive, are there any differences in recommendations for both quarantine and isolation with symptoms versus no symptoms, or vaccinated versus unvaccinated?
Yes, yeah. If you are if you become detected by either symptoms, what you do with that one first. If you're symptomatic and you get tested, the standard and the ideal recommend, the optimal is that 10 days of isolation with at least 24 hours of asymptomatic. No, you're feeling well, that has resolved. Those there is options within healthcare workers, particularly where you can shorten that to 5 days, sort of essential workers, and again, you would wear masks for those last 5 days. If they are asymptomatic and they have been vaccinated, they don't have any necessarily be excluded, but they have to have a mask and do all of that. If they're unvaccinated, then they sort of fall back into that same category as if they were symptomatic, and should not be there for the 5 days and then wear the mask for the subsequent 5.
I would say I think the CDC's website actually has a great algorithm that you can click through for all of those scenarios, and they do keep it up to date with their most recent recommendations. I've referred a few patients there. We utilize it and double check, with our office protocols. It's fairly easy to use. It works great on a mobile device as well. So for anybody that doesn't know it's there, you can look up information regarding if you have an exposure, what to do with positives, how long to isolate. So I think it's a great resource for everybody to know about. I'll ask Dr. Kim, this is a common question regarding patients in the hospital. If there are COVID positive patients, whether it's in the hospital or home, any recommendations on family members when it comes to the care, guidelines on how long you need to be in a room to really consider that a meaningful exposure?
Well, I guess it's now what, 15 minutes if you're both, but a certain amount of it is also probably judgment. If you're just in the room, whether you're masked or both of you. I mean, in hospitals often, well, not these days, but it used to be that people were supposed to wear masks, and also how close you're taking care of patients. Like if you're some people who visit are really caregivers, so it's super close contact, and so that's going to be a pretty close contact. So there's a certain amount of judgment associated with all of that, and then the rules are very similar to what Dr. Holt delineated. So a lot of it is a little bit of judgment.
We've heard a lot about masks in the last few comments, and so we did get a mask question. Really large cities like LA and New York are recommending masking. They haven't really come out with specific mandates. I don't want to put words in anybody's mouth. I assume we're all still proponents of masks as a way to help control spread. And then do we think that in our area, the relaxation of mask mandates has caused such a rapid change of the positivity rate in the numbers, or more of the infectivity of the virus despite masks going away?
Both. I think, but it's very infectious. But the thing is also, this area is less dense than New York City. So anything can spread really quickly in New York City. So I think, it's both things. And, and I think that, people are a little dubious whether masks worked, but I think when we started throwing away our masks, RSV and influenza came back, and they went away for a long while. So I think, so I think masks work. And I think anecdotally, I think you alluded to it, all of us who are, as particular healthcare workers, it seems to have swept through all offices and things like that. And I know a lot of people who have gotten, COVID on vacation. So I think, particularly, it depends on what your situation is, your tolerance for risk. Fortunately, we have good treatments and people are vaccinated, so they get sick, but they don't get that sick. But if it were me and I either didn't want to get it, or I had some other medical problem, or I lived with somebody that had a serious medical problem where I didn't want to give it to them, any kind of dense place where I was at, an airport, a grocery store, on an airplane, I would wear a mask, and that's what I still do. I'm actually from New York, so yeah, I wear a mask on the subway. Does everybody? No. But that's what I would do, because I was also one of those people who got COVID, and I didn't get very sick, which was wonderful, but I still did get sick, and if you can avoid it, you can avoid it. And I would probably, in areas that are higher risk, I would definitely wear a mask.
I'd like to transition over to some treatment information, really starting with how we triage our patients. I would say potentially leaving out the immune compromised since they're a specialty category. If a healthy patient with no major medical problems calls the office and says they've been diagnosed with COVID, I'll go with Dr. Sinnott. What would your advice be other than making the recommendations for isolation versus not? And who do you send to the emergency room other than transplant patients or severely immune compromised?
Okay. I have a fairly extensive home protocol for patients. Although we want to get rid of the virus, it's really the symptoms that make us sick. And the symptoms are really immunologic. It's tumor necrosis factor, IL-1 for fever, IL-2 for aches and pains, etc. So to get rid of the virus, I will look at the patient and say, can they take Paxlovid? 20% cannot because of medication interactions, and they'll go on molnupiravir. Then I'll assess their age and immune status. If I have any question about it, and it's surprising to me how often people that are quite ill minimize it, and people that aren't sick maximize it. So I try to get a good feel for what am I talking to, okay? So if I have a patient with they're recovering from breast cancer a year ago, something like that, I'm not going to mess with those people. They're going to get Paxlovid. I'm going to call their oncologist to make sure there's no drug interactions and that they know what I'm doing, okay? And then I would set them up for them to get bebtelovimab intravenously. That's 10 cc's of pure anti-spike protein. As I do that, I think about how am I going to manage them to treat their symptoms? Okay, nobody calls up and says the virus is bothering me. I have a sore throat, I have a cough. So number one, to follow them, I like an oximeter. I tell them to buy an oximeter and a humidifier at the pharmacy. I want them to text me a picture of the oximeter each day, so it's part of the medical record. If their pulse is going up, they're dehydrated, okay? If their PO2 is going down, it gets 92 or below, they're going to the ER. But that's actually very rare if they're getting Pax and bebtelovimab. Matter of fact, I've only had that happen twice. And that's out of a couple hundred patients. Then what I see with BA4 and BA5, and it's not just my observation, is that the previous strains took away taste and smell. BA4 and 5 take away thirst. So all these patients get dehydrated. So I have them take 2 quarts of water a day, or 1 quart of water mixed with a quart of Gatorade, something like that. I want them to keep their heart rate under 100. If it goes over 100, they need more fluids, just as a general rule of thumb. I make them rest. No matter how they feel, they're to rest. For comfort control, I alternate aspirin and Tylenol, maximum dose. So at noon, you take aspirin. At 4 o'clock, you take Tylenol. At 8 o'clock, you take aspirin. At midnight, you take Tylenol. The highest dose the bottle will let you take. Although steroids should be used with caution, I get a lot of results out of Flonase, the over-the-counter steroid, which is not well absorbed, but it relieves a sore throat immensely. Although you use it nasally, it runs down the back of the throat. It keeps the airway open and stops you from mouth breathing. It also reduces coughing. So patients enjoy the Flonase very much. And very important, and maybe most important, is an old-fashioned humidifier for $30. If you call, or if you're on Amazon, they'll have it to you within 12 hours. And you should have that. It's so funny, patients put on humidifiers, a lot of times keep using them, And one of my affluent patients built a steam room. So they like that because you're relieving symptoms. You're helping the sore throat, helping the, plus when you get wet air in the lungs, you're coughing up stuff that when they send you pictures, you can't believe it. I mean, looks like you have aspergillus of the lung or something. This brown, black stuff. So you're actually physically mobilizing secretions. You're getting all of some virus out, but especially the inflammatory molecules come up too. 20% of patients on Pax will get a very bad taste. That taste is because Paxlovid is of all things excreted by the tonsils, which makes it a miracle drug. I mean, how they come up with this stuff. Now, for that taste, some people will tolerate it, others won't. Listerine, as much as they want, will get rid of the taste. Brushing their teeth a lot will get rid of the taste. A teaspoon of baking soda and half a glass of water will very much get rid of the taste because the taste is acidic and you're using a base to wash it out with. Diarrhea is common with COVID. It's actually very uncommon with Paxlovid. So when you tell them ahead of time, you might get diarrhea, but it's from the virus. Don't stop the Paxlovid. Treat through it, it'll get better. If it's really bothering you, use Metamucil. For severe sore throat, you're a little limited in what you can do, okay? Warm liquid with honey, saltwater gargles about the same strength as ocean water. And I reassure them that if you're on Paxlovid, the sore throat lasts an average of 2.2 days. And then it gets better. You want to make sure they take the Paxlovid on a full stomach. And finally, occasionally you'll find patients that are insistent that they sleep. The only sleeping medication you can give them, other than say an antihistamine, which really isn't a sleeping pill, is temazepam. It's not affected by cytochrome 384. So you can give that to them with confidence. Temazepam, 15 milligrams. You must be very careful with opiates because Paxlovid blocks 384, that metabolizes opiates. So 10 milligrams of oxycodone actually become 40. So you've got to be very careful there. Now, I've had some patients I've had to give opiates to between cough and pain. And in that group, I have them take a 5 milligram oxycodone, cut it in half, so it's 2.5, or even smaller, and dissolve it under their tongue. So there's a topical effect on the throat and cough. And that the patients I've found in my experience work. Finally, if you really have an issue with coughing, use the low strength Advair, 2 puffs twice a day. Now, of course, when you look at drugs.com, they'll say there's an interaction, but you have to balance out with them breaking a rib at the age of 70 from coughing. So I do that comfortably. I don't lose any sleep over it. Finally, I think in the past 2 weeks, there's a realization that of all things, the vagal nerve is number one damaged by the virus. Recall that autopsies are not done on these patients because they must be done in a level 4 biohazard facility. And that's like Emory's biohazard facility. But they're finding that the vagal nerve is directly infected by the virus, which is why we think they get POTS syndrome afterwards, and to a large extent, chronic disease. Of all things at Cornell, they found out that high-dose famotidine 80 milligrams 3 or 4 times a day is vagal protective. And also, as you protect the vagal nerve, the vagus nerve actually is an immune activator. So you're protecting them. And I've had surprising results with that. There's no, well, first, you don't ever have to worry about reflux for a while, but it's 80 milligrams 3 or 4 times a day. Just get it over the counter. Don't discuss it with the pharmacist who have a nervous breakdown. Just go home and take it. You won't even know you're taking it. And I have ample data to support that selection. I hope that was helpful, but like I said, they're patients. We want to treat the symptoms. You know, I can treat the virus, but I need the patient to feel better soon. And then I tell them to rest. Please don't go back to work till day 10. Everybody goes back to work too soon gets sick again. Is that helpful?
Absolutely. That's a lot more information because you got symptoms involved and covered there too.
Sure.
Dr. Cancio, I'd love to hear your take on kind of the standard patient that calls in too, to see what's similar and different, or if there's anything you'd want to add. And then I do have a couple of questions about some of the talk about rebound adverse effects after Paxlovid to see what we understand about that. What's your take on the average patient that calls in that you determine wouldn't need to be admitted right away?
Well, the main 2 reasons why you would admit somebody would be you think that they're totally dehydrated. We also have, or they have hypoxia, or they don't have access to something that they may need. That would be, we have had we have not had as many hospitalizations as we did in the prior waves. So we are treating a lot of patients as an outpatient. And we try to tell the patients that as soon as they are positive to call. And again, we also share the same idea that Dr. Sena said, which is early antiviral therapy works. Paxlovid has the number 1 to 10 problem with Paxlovid is drug-to-drug interactions. You have to tell the patient, I need a full account of every medication over the counter from your friend, from everybody. I want to know if you're putting it in your mouth, I want to know the name of that medication. That is the most important thing. The other thing you need to know is the renal function, because the regular dose has to be decreased if the patient has renal insufficiency. Most ID doctors are very familiar with the drug interactions of Paxlovid because the problem in Paxlovid is a drug called ritonavir that we have been using on HIV for many years. We no longer use it because now we have better drugs, but we used it for a long time. So we understand the side effects, we understand the side effects, and we also understand the issue of drug interaction. But that's very important. We do have an alternative drug, molnupiravir, for those patients that cannot take Paxlovid, but an antiviral therapy is important. The selected patients, I take care of a lot of transplant patients, and using the monoclonal antibody can be very helpful on those patients to prevent them from getting sicker. The regular population, we don't, unless it's we may not have access to that. There is a limited supply of monoclonal antibodies, so we use it on selected patients, such as transplant patients or patients that would have a very high risk because of their age or their comorbidities, things like that. And then we go very much symptomatically, like Dr. Sena said. I mean, the fluid resuscitation and loss of fluids is really important. Gargles, we do use the Baconates, like he was saying, or Flonase for the nose. Inhalers when needed. And if the patient after like the first week is still feeling poorly, then that's when we go with steroids. We also address the patient for the possibility of hypercoagulable state, and that one is pretty specific for the specific patient. So those are the things that we're looking at, but we actually try to prevent the worst thing that can happen to the patient is get admitted, and the use of the antivirals can prevent that. And we do use it. So we do a lot of telemedicine consultations on patients so that they don't come to the office and infect other patients or our staff. So which is patients of record, you can do a telemedicine consult and follow them that way. And we kind of tend to call them frequently and make sure that they're doing okay, because as they progress, you may need different things. You may have to add Advair, you may have to add steroids or something else.
Can you speak a little to the rebound symptoms of Paxlovid? Are they symptoms only, or is there any chance of infectivity changing during that time? Would they be able to transmit the virus more easily, or do we think that it's still the same life cycle of the virus as opposed to just the symptoms that patients can have as what they've been calling the rebound, or several days after starting the Paxlovid and feeling better and then reverting back to same symptoms?
I think there's data now that the Paxlovid, the rebound, number one, the rebound happens, but it's not horribly common. I think that the media has over-exaggerated that one a little bit, but it does happen, and we have all seen it. And I think that all of us here that take care of patients have seen it. So that's one issue. Issue number two, we know that it's not because the virus is becoming resistant to Paxlovid. There's some studies that have shown that. And yes, you can have increased infectivity again and increased viral load after that. And if the patient is symptomatic, we keep him on isolation. We have done some other creative things, but I'm not sure that we like putting them on molnupiravir afterwards, but yeah.
And last follow-up question to that, this one will be a selfish for my own purposes. Can you speak to any options that we have other than symptomatic treatment for our pregnant patients?
You can give them monoclonals.
Mm-hmm. So that is one of the indications that
monoclonals are totally safe. Monoclonals are totally safe on the in the pregnant patient. So that would be a case. I mean, especially because bad COVID is not good for a pregnant patient. So monoclonal. So number one, I would make sure that all my pregnant patients are vaccinated, and that they have been boosted, that they have that protection. And then if they get sick, that is a monoclonal therapy with monoclonal will be important for that patient.
Though there's now evidence, we would not give molnupiravir, but I think now that we've had more experience with Paxlovid, I think it's more accepted to give people Paxlovid, though I think a lot of practitioners, if they could get someone in for monoclonal antibodies, would use that preferentially. But I think the safety profile for Paxlovid, it's emerging that you probably can give it to a pregnant woman, but of course it's got the usual, we don't know. But we definitely would not give molnupiravir.
Right, and actually the Paxlovid, remember that ritonavir part, we know that we have used that on HIV positive women in the past. So we know that part would be okay. So that is not the part that we would.
In consultation with some OBs, I've treated 2 pregnant women with Paxlovid. The outcome and bebtelovimab, these were later age, in vitro fertilization, high-risk patients. But when you explain the risk of the illness to the patient, they tend to be, these individuals seem to be better educated and pretty accepting and say, yes, we'll take that. So we certainly have experience with at least 2 patients in consultation with the OB.
Have we had any new information regarding some of the original possible alternative treatments, ivermectin, hydroxychloroquine, just come up as examples? Anything that was ever floating around have any new data, whether it's supportive or even less supportive now? And I will open that one to anybody, since I'm not sure who may or may not follow anything there.
I keep this on my desk for patients I don't like.
all the guidelines, whether the Infectious Disease Society of America, the Hippocrates, every single guidelines is no, 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 no. So the answer is no.
You must not use any of the chloroquine drugs with Paxlovid. That would be very serious.
Dr. Holt, I'm very interested to know if you follow, and this will be kind of transitioning to looking forward in hopes to try to predict the future. Is there a country or countries that we can follow that best predict the course of action that the variants have taken, in our country? Has there seemed to be somebody we mimic that we can look at?
Well, looking ahead and predicting, particularly the variants and others, I don't know if I could, as Dr. Simmons said, these can emerge anywhere and everywhere. I think we get more information out of places like the United Kingdom and places where they're doing a lot of sequencing, and they know they have a deeper sampling of their test of their viruses. So I don't know if I would look for one country as my bellwether to predict it.
Since the world has opened up and a lot of people, I think that Dr. Kim said it best, your risk tolerance decides if you want to do, whether it's activities near or far. Travel really is becoming a lot more common. Are there any areas or resources that we have where you can see where not to travel to, other than just the CDC website, or are there any regions that you would advise not to for any specific reason? Dr. Holt, I was going to follow with you there.
From a COVID standpoint, I think my biggest concern wasn't necessarily that I would be more likely to get it, but perhaps what kind of care would I receive if I did get it. So I think I would use that in my determination, and that's just my own personal assessment. Certainly welcome any other world travelers that are in the panel.
I actually got asked that the other day. The safest place in the world to visit is the Vatican. I highly advise, if you don't want to get COVID, go hang out there. They've had a total of 29 cases. They require masking everywhere. Other than that, American Samoa, because it's remoteness and you have to wear a mask, has very low cases. So does do Palau and Vanuatu, isolated areas of the South Pacific that have a strong Asian influence that wear masks.
I have had a lot of patients asking specifically about treatment. When they travel, they've assumed that, or they've decided that they're willing to take the risk with travel, but they ask questions about traveling with medications or, considering treatment options if they were to be sick abroad. And now that the United States has dropped the testing to come back into the United States, I think that that'll also complicate things, which is the transmission rate and people even being aware that they're sick while they're traveling. Would you ever recommend people do travel with any of the medications? Or are we not in a situation where we can, prescribe something like Paxlovid as more of an if I fall ill? Dr. Sinnott, I was asking specifically.
Well, supposedly, you're only supposed to give Paxlovid by the EUA to patients diagnosed by rapid test or PCR with COVID-19. Now, if I had hypothetically, if a physician in good health and not on a bunch of complicated medicines was traveling, they can write themselves a prescription for Paxlovid and take it with them. When they do that, they should take 2 rapid tests a day. And at the hint of anything upper respiratory, they should test, okay? And that would be one way to protect themselves. I'm a little leery of civilians in a way, because I don't know what they would perceive as a fever or a sore throat or something like that. Because once you're outside the EUA, you're on your own. You have no defense against that. Was that helpful?
Yeah. There's a new subvariant that I saw listed called Centaurus, or BA 2.75, I believe. Dr. Kim, any thought if that's been seen in the United States? Do we anticipate that that's very likely we will eventually see it? And do we know anything about vaccines, and does it seem to be that we're still limiting severe disease if we're vaccinated?
I don't remember the molecular equity. I think we have seen it in the United States. It's, except for the ones who've really swept through, like Omicron or Delta, where it's just pretty clear that it was vastly one thing and all of a sudden it was vastly another. These new variants, it's so hard to tell because, it's dizzying and, you don't keep up with it probably as much as, but there was, Lambda, there was, this strain from, South America, there's, and, a lot of them didn't come to pass, even though they caused little blips. So exactly what's going to happen until they really, really emerge, and some areas shows that they were like, there was none, and then there's all of a sudden it's 10%, and then it's 50%. It's really, really hard to predict. So this particular one, I don't know, but I think, it's all the sort of same thing, use some sense, be vaccinated, don't take unnecessary risks. And which one is the next one that's going to definitely emerge? I think the jury's still out. Doug, do you know more, or John, do you know more about how much of this one we've seen in the US?
I don't know that it's been seen in the US. I do know my colleagues in Southeast Asia say that it's causing a great deal of trouble in Malaysia and Vietnam.
I'm going to wrap up with the last few questions and then make sure I give an opportunity if anybody else on the panel wants to put something into the question and answer. Last two questions, I guess three I actually have. So Dr. Cancio, there's so many voices nationally and internationally. Can you give recommended guidelines? I think the CDC is the most obvious, of any other recommendations on who to follow and where physicians can try to find some synthesized information? Basically, which voice should we really listen to?
We actually, the Infectious Disease Society of America has a very good website and has worked with the big organizations, and where with the recommendations for vaccines, for therapy, hey, you can put Hippocrates on your phone and it has an excellent recommendations. So I think that there's a lot of good information in terms of isolation and infection control. I think CDC has done a really good job. So I think that for isolations, I think CDC has, like you said, that algorithm is pretty easy to follow, and they're keeping up with it. In terms of therapies and vaccines, I think that Infectious Disease Society of America, and even just having Hippocrates on your phone, can give you really very up-to-date information, and it gets updated all the time.
Dr. Holt, do you have any specific recommendations since school starts up in about a month, other than the basis we talked about, hoping for vaccination and boosters when appropriate? Thoughts on school?
Here we go. Yeah. I think certainly get your child vaccinated. I mean, I think that's the recurring theme. There will not be masks. There's not going to be any social distancing, and it's a prime environment for transmission. And childhood vaccine, so it's always a good time we knew that. But I would anticipate that your child will be exposed, and take everything you can to limit their severity of their illness, and falls back to vaccines.
Do you anticipate we may still see a high flu rate, since we're still seeing flu diagnosed so late in July at the same time?
I think this could be the year. Yeah, when you think about everything else, we've already seen a little early uptick. Certainly, much bigger than we've had for the last 2 years. So, and we've seen other respiratory viruses being transmitted. So, yeah, I think it's going to be quite a viral soup out there.
We did have a question come in. I think this is great, and I'll open it to anybody. The best way in the Tampa Bay area to get monoclonal antibodies right now, once the public sites from Florida kind of dissolved, are there any recommendations that you have on where private practice physician would be able to send a patient for monoclonal antibodies in the appropriate setting?
I myself, DirectX, it's a pharmacy. It's expensive. For $750, a nurse will take the medication to the patient's home and infuse it. Obviously, not everyone can afford it. I do know there are 2 other competing companies that do not offer nearly the service or professionalism that DirectX does. I can give you a phone number. I have no financial interest in just reporting the news. Would that be valuable to you?
I think so. If there's a limited number of resources, that anything that we can help to provide for we can even list it on HCMA, or at least have patients, or excuse me, physicians have an idea of where they may be able to find better information.
Tampa General Hospital.
We use our office uses that same company, again, with no financial involvement whatsoever. And they do a very good job. The problem is that the monoclonal comes from the government, but the infusion is no longer covered. So the patients have to pay for it. Tampa General does have some monoclonal antibodies, and for selected patients that will be very high risk. Like, for example, a pregnant patient will probably get it, transplant patient will get it, not enough for anybody. My understanding is that some of the other hospitals have some, but it's really hard to get. Like I just recently was involved a little bit of ACA, South Tampa, Old Memorial. Actually, they have the antibodies, but they're not really using it very much, and we're in the process of trying to convince them to do so. Because the amount of antibody available and the resources are very limited. So if they have it, they should be using it. But for the particular patient, those are the options: hospitals or having to pay for the infusion. There's not really any other resources that I'm aware of.
Yeah, I was about to say the same thing. And for those who don't get their ongoing care at Tampa General, there is still a web portal that you can basically put in a referral. And because the supply of Tampa General is fairly limited, it tends to be people who are at the most medically at risk, but you will have somebody basically get back to you as far as the triaging process. And if you're eligible for Paxlovid, can walk you through the process to make sure that you can get Paxlovid or molnupiravir. So for people who don't have the financial resources, there is potentially a way of getting it through the Tampa General web portal, even if you're not a regular Tampa General patient. But like I said, warning you, because the supplies are very, very limited, the criteria for getting it are pretty stringent. So the most at-risk patients.
Looks like the last coming through. And so my last question, I think Dr. Sin is probably the best for this specific question. Is our next webinar going to be called the Monkeypox Town Hall, or are we going to stick with COVID and not necessarily see monkeypox become anything to this scale?
Monkeypox is not going to be anything to this scale. Even if monkeypox becomes much more prominent, actually all of us have talked, and obviously we've been in the infectious disease community for a while, and we all work very closely together. So we compared notes and worked to develop guidance. Dr. Holt has been his usual very helpful self as far as helping all of us in practice deal with it. And even if we see more monkeypox, it will not be what we've just been dealing with COVID.
I'd like to thank you. We've hit.
Actually, I want to say that we're seeing cases already in this area. We have diagnosed several cases, and the population at risk is at risk, and we do need to make sure that all of our gay patients, men having sex with men, HIV patients are well educated, because we're seeing a lot of exposure in that population. And now there's very limited vaccine availability, but there is some, and if they're able to do that, that can be helpful. But Dr. Hall knows the most about this.
Look at that. It is very different. We know much more about the virus than we did with COVID, with the transmission routes. While it is contagious, it's not highly contagious. We do have vaccine, as Dr. Cancio mentioned, not enough yet, but it's being mobilized, and so we can both vaccinate those that were exposed, the post exposure prophylaxis, but also those high-risk populations will be giving them for prevention. So this is one of the times where we actually have a chance where public health epidemiology, the identify contacts, contact trace, break the chain, we have a realistic expectation that this will be effective. And I don't believe it will be eliminated, though. It has, I think it's established. So for those physicians, when you see a rash that not sure of, think about it. It should be in the differential.
And by the way, both Quest and LabCorp already have the ability to test for them. In our office, we already have seen 3 cases. Again, we target that population, so those are our patients.
I find it very interesting that almost every virus we've spoken about tonight is an RNA virus. Out of just my personal curiosity, have there ever been any DNA viruses that can create the same type of like pandemic, large scale volume changing as rapidly, or does it really seem to be mostly in the mRNA world? I'm sorry, the RNA.
Well, monkeypox is a DNA virus. Monkeypox is a DNA virus, and smallpox is a DNA virus. So some of these, though, they tend to mutate a lot less than RNA viruses. So you're absolutely correct about that. But depending on how virulent they are and how easy it is to get, DNA viruses can cause problems.
Again, I've always learned so much during these both practical, scientific level. We really appreciate your time. We know how valuable it is. I definitely want to extend my thanks for all the physicians and members that have tuned in. If we decide to do another, of course, we'll reach out. Hopefully these can become fewer and farther between as we learn how to, I know everybody's kind of tired of the term, the new normal, but ultimately that is what we're navigating and trying to understand what's best from public health, personal as physicians, and trying to do the best thing for our patients. So we really appreciate everybody's time, and I want to wish everybody a good evening.